Thanks again. Thank you for the invitation. I do promise to be there next time. And so I'm here because I run the CPET lab at the University Hospital of Crete. Um, we we do not have we do not see that many patients with interstitial lung disease, but I think I have seen practically all the patients with pulmonary hypertension that are able to come to the hospital and come to my lab. So for the next few minutes, this is what I will be talking to you about. The combination of pulmonary hypertension and interstitial lung disease is quite common. It affects roughly about a third of the patients, which of course varies a lot by the type of interstitial lung disease. And the reason that it is so common is that the underlying mechanism is similar. The inflammation and fibrosis that affect the lung also affect the vascular bed and result in the pulmonary hypertension. What does that mean for the patient? It means worse exercise tolerance, and that translates in worse quality of life, greater hypoxemia, and earlier and more severe need for oxygen supplementation, and basically worse prognosis. Most importantly, it requires management for the pulmonary hypertension, and that's why it has to be diagnosed as soon earlier rather than later. Now, continuing with these introductory slides, a few words about the cardiopulmonary exercise test. It is a symptom-limited exercise test. The subject is exercising using a bike or a treadmill, and the intensity of exercise progressively increases by either increasing the resistance in the bike or the combination of speed and slope on the treadmill. With a mask attached on the face, with specific equipment, we measure flow, expired oxygen and CO2 concentration, and at the same time, we monitor pulse oximetry, ECG, and blood pressure. We ask the subject for dyspnea, fatigue, leg pain, or other symptoms, and we calculate from these values the oxygen consumption, CO2 production, tidal volume, and respiratory rate to calculate the oxygen, the VO2 max, the thresholds, and delineate the cardiovascular and respiratory responses to increasing ventilatory demands. I will take a few moments of your time to remind to the audience that I don't know what is if they're all experts or not, some basics of exercise physiology. So when we exercise, our working muscles need more oxygen and they will produce more CO2. Our body responds to these increasing oxygen demands by increasing heart rate, stroke volume, and oxygen extraction. It has to respond to these increased demands of higher CO2 production and the need to maintain constant CO2 levels by increasing mean ventilation, tidal volume, and respiratory rate. A little bit more of physiology and physiology of exercise. The exercise can be discriminated in roughly 3 levels of intensity. The low intensity exercise, which is sustainable and well tolerated. VO2 is more or equal to CO2 production, and that happens because with the mitochondria are adequate and have enough time to produce energy using the oxidative phosphorylation. As exercise intensity progressively increases, and we now move on to what is called moderate intensity exercise, this mitochondrial source of energy production is not sufficient anymore. So what happens is that there's more glycolysis, which means more pyruvate that can be absorbed in the oxphos, and then this turns into lactate, which is an acid that will be buffered from the bicarb system to increase the CO2 production. And from this moment onwards, CO2 production is excessive to oxygen consumption, and for the body to maintain the stable PCO2, ventilation needs to increase. So we identify this first slope as an increase in ventilation. Progressively increasing intensity of exercise leads us to this second threshold, where vigorous exercise begins. Vigorous exercise can be sustained for only a few minutes, and it's characterized by progressively exhaustion of the bicarb system and decreasing pH, which simulates the control of breathing system to further increase ventilation, to now decrease PCO2 and cause respiratory alkalosis to compensate for the metabolic acidosis. And we have this sharp rise of minute ventilation. Now, a normal CPET looks like this: a progressive increase of oxygen consumption, increase in CO2 production that at some point becomes excessive to oxygen, as I said, linear increase in heart rate and of stroke volume, increase in systolic and drop in diastolic blood pressure, increase in tidal volume, and an increase in respiratory rate. Now, this VO2 max that nobody now hasn't heard of. The VO2 max, the max reported overall, belongs to a Norwegian cross-country athlete. I don't remember the name. It's about 100 mL per kilogram. A 25-year-old athletic person has a VO2 max of about 50 mL per kilogram, not professional athlete, just reasonably active. With double this age and half the time to exercise, a 50-year-old person who is not athletic will have a VO2 max of about half of it. And adding another 25 years and an interstitial lung disease would result in a patient now having a VO2 max around 12 mL per kilogram per minute. Why am I telling you these numbers? Because at first we said that pulmonary hypertension and interstitial lung disease lead to exercise intolerance. Now, not tolerating exercise doesn't sound like a big problem. I mean, I wouldn't mind not going to the gym ever again. That wouldn't affect my quality of life. But everyday living is exercise. And I would like you to show you these rough estimates of VO2 as ml per kilogram per minute for activities of daily living. So for personal hygiene, cooking, or really slow walking, you need about 8 ml per kilogram per minute. For basic housekeeping, you need about 10 to 12. And if you have to get out of your house and use the stairs, you will need 12 to 16. And if you have to carry your own groceries, you will need also that much. So you understand now that when a person has the VO2 max of around 12 per minute, it means that to carry the groceries back home, that's maximum exercise. And activities of basic living become hard to tolerate excess level of exercise. What does training do? Well, it improves fitness. Everybody knows that, and it increases muscle mass. But it does more than that. It increases the muscle vasculature, enabling more oxygen to be delivered. And it does this, which is very, very important. It increases the number of mitochondria in the muscles. So the muscles become more effective in producing more work with less CO2 production. And less CO2 production means less work for the lungs and the cardiovascular system to remove. That's why it is important in conditions where elimination of CO2 is the limit of exercise capacity. And this is an example of a CPET test in a patient with interstitial pulmonary fibrosis, with IPF, who finishes exercise due to dyspnea of 8 to 10 at a VO2 max that is much less than the predicted for the patient's age. Now, when we analyze a CPET test, it's not only about VO2 max or VO2 peak. The CPET beautifully shows the complex cardiovascular and respiratory physiology of exercise in lines and curves. And it's a great underestimation of the test to focus the result on just this value. So in terms of value, what we learn, and it's important for the patient, is the thresholds, first or threshold, and the second, the slope of VVCO2, which is the efficiency of ventilation, how much ventilation you need to increase your ventilation for a given increase in CO2 production, and the breathing reserve. Kinetics, more important, I think, the end-tidal CO2, heart rate, the slope of VO2 to heart rate, the so-called oxygen pulse, how increase in minute ventilation is achieved by increasing tidal volume or respiratory rate, respectively, and their relative contribution and kinetics. The time and how fast hypoxemia may develop, flow volume loops to identify an obstructive component, and obviously cardiovascular responses as blood pressure and ECG. Also, the time and conditions under which dyspnea and leg pain or fatigue develop. Now let's move to guidelines. So in interstitial lung disease, the CPET is considered to be indicated for patients who have symptoms of exercise intolerance, and as a way to suggest determine the likelihood of pulmonary hypertension. Particularly in patients with scleroderma, exercise or CPET may be considered as aids to facilitate the decision to perform the right heart catheterization. And again, similarly, in any population at risk of pulmonary hypertension, again, patients with scleroderma, a normal CPET may help identify patients at low risk of having pulmonary hypertension. I'd like to point out here that for this to be valid, the patient should not be suspect of having been very, very fit in his previous life before getting the disease, because what we can identify is a deviation from the expected, but if a person has been very, very fit in the past, we may miss it. On the diagnostic algorithm, again on the guidelines, from patients who present with unexplained dyspnea or are anyway suspected for pulmonary hypertension, the role of CPET is down here after the pulmonary function test examination or the echocardiogram. So when the patient develops pulmonary hypertension, the specific findings on the CPET is a low and non-increasing end-tidal CO2, a high or often very, very impressively high VVCO2, a lower, flatter than normal VO2 to heart rate slope, and a low VO2 peak. That's really the most non-specific finding, and a low heart rate recovery. So that the drop of heart rate at the end of exercise is not as fast as it should be. Again, on the guidelines, the role of CPET in the assessment of risk in patients with pulmonary hypertension. These are the thresholds used, 15 mL per kilogram and a slope for 36 to identify the low risk, 36 to 44, and between 11 and 15 for intermediate risk, and 11 or above 44 for high risk. Smaller studies have shown other indices to be able to contribute to risk stratification, such as a high resting heart rate, a low peak heart rate, and a reduced change from resting to max heart rate during exercise, as shown here with patients having worse survival when their change from rest to peak exercise was less than 27 beats per minute. Again, from the guidelines, the suggested assessment, the suggested repetition of CPET in the assessment of patients with pulmonary hypertension is at the level of may be considered, and may be considered at every visit 3 to 6 months, and in case of clinical worsening. Just a few words about exercise-induced pulmonary hypertension, because it is frequent in patients with interstitial lung disease. What happens is that there is a disproportional increase in pulmonary arterial pressure in response to increase in cardiac output. That suggests an abnormal vascular response to exercise. So increasingly, the pulmonary vasculature becomes unable to tolerate increased flow. That is the threshold used to identify exercise-induced pulmonary hypertension is a rise of mean pulmonary artery pressure more than 3 millimeters of mercury per liter of increase of cardiac output. It appears earlier, that's why it's important, and it is associated with more exertional dyspnea, higher VEV-CO2, lower SpO2, and earlier first threshold. However, none of these variables is able to discriminate the patient with exercise-induced pulmonary hypertension, so we have to do the invasive exercise test. See here from this publication from Mass General how patients with exercise pulmonary hypertension are nicely discriminated from patients with interstitial lung disease but not vascular disease and controls. It is also important because it is associated with a twofold increase for cardiovascular events or death. The invasive CPET is just like the normal CPET, but the patient is also wearing a pulmonary artery catheter. Another modification is that it is suggested to make, rather than a continuous incremental exercise, a stepwise increase to allow some steady state to obtain the measurements of cardiac output. Do you have a couple of more minutes? Okay, I hope I do.
Just 2 minutes.
Okay, so dyspnea is an important and devastating symptom, and dyspnea occurs in patients when the ventilatory demands are not able to be met by the capacity of the respiratory system, and every time the output exceeds of the muscles is less than what the brain expected. So here an old study showing how breathlessness develops in patients with interstitial lung disease and is associated with great effort for the same ventilation. So this occurs because patients, especially when they have the combination of interstitial lung disease and pulmonary hypertension, have both altered respiratory system mechanics with increased elastance and dynamic hyperinflation frequently, impaired gas exchange with hypoxemia and vacuum mismatch, and that leads to earlier first threshold, further increasing the need to increase ventilation, and that's often accompanied by respiratory muscle weakness. And in this nice review, which maybe Dr. Mitruska will be able to tell you more about it at some point, she has nicely described how the respiratory system is the main determinant of dyspnea in patients with pulmonary hypertension. As in terms of prognosis, low peak VO2, less than 50% or 15 ml per kilogram, is strongly associated with mortality, and so is high VEV-CO2, although studies have identified different thresholds ranging from 35 to 45. Also, hypoxemia and the magnitude of DAA at maximum exercise. I'd like to point out that in the spectrum of treatment of patients with interstitial lung disease, and especially with pulmonary hypertension, it's important to consider early rehabilitation because it does improve exercise capacity, and it, more importantly, improves quality of life by allowing the system that is challenged and not able to cope with higher loads to have stronger muscles and so less demands. So to conclude, the role of CPET in pulmonary hypertension and interstitial lung disease is to help identify the patient who should get right heart catheterization, characterize disease severity, assess the magnitude of functional limitation, and also the key determinants of dyspnea in these patients. It also enables personalized exercise prescription and monitors the response to treatment. Again, the CPET is a very beautiful test, and it's so much more than the VO2 max. So thank you very much for your attention. And if you don't send your patients for a CPET, at least send them to walk the Cooley of Iraklio. Thank you.